First of all, let me just introduce myself as Robert Straka, as the department head for the Experimental Clinical Pharmacology Department. It's my tremendous pleasure on behalf of the entire Experimental Clinical Pharmacology DEI Task Force to welcome each and every one of you to this event. Let me say that our entire task force members have been working hard over the past while to provide this opportunity for all of us to learn and reflect and exchange our thoughts and ideas about today's presentation, and hopefully result in some action beyond that. The general format for this meeting is that in a short while, we'll formally introduce our guest speaker, which I'm very excited about for today's presentation. And also kind of it's more or less going to be a very informative and motivating talk for all of us. This talk is expected to last about 45 minutes, and we intend to have a short Q&A session after which we'll invite all of the attendees to stay on for an additional 30 minutes or so to engage in an activity that we plan to have in breakout Zoom rooms, so to speak, in terms of facilitated discussion. And there are some questions that have been pre-planned for that to stimulate that discussion. So our hope that that discussion in particular and reflection upon the content of this very informative presentation will be helpful in our mission to facilitate actions that we can all take to advance our appreciation for diversity, equity, and inclusion. On behalf of the committee, thank you all once again for your participation in this activity. And I will now invite Dr. Laurel Johnson, a member of our ECP's DEI Task Force and College of Pharmacy's Director of Diversity, to formally introduce our speaker. Thank you.
Thank you, Dr. Straka. It is my extreme pleasure and honor to introduce our speaker for this afternoon. Dr. Ahmar Zaidi is a pediatric hematologist, oncologist with a special interest in sickle cell anemia disease and hemoglobinopathies. He received his medical degree from the Medical University of the Americas in the West Indies. He completed his residency in pediatrics from Beaumont Children's Hospital, followed by a fellowship in pediatric hematology oncology from Children's Hospital of Michigan. Dr. Zaidi is now the medical director, clinical development at Agios Pharmaceuticals for their Sickle Cell Disease Program. He has served as a co-chair of the Anti-Racism Task Force for the American Society of Hematology. It is a pleasure to introduce Dr. Ahmar Zaidi, who will be presenting to us about Sickle Cell Caste from the single mutation to the victimization and the road back. Thank you for being present.
Thank you both for your kind words and introduction. Let me go ahead and share my screen here. Let me know if you can see that.
We can see it.
Yeah, okay, good. Oops, and just as you told me you could see it, I went ahead and unshared, so that's good. One sec here. All right. Well, once again, my name is Ahmar Zaidi, and I am just thrilled and honored to be with you all today, and I appreciate you sharing your time with me. I know how valuable time is these days, so thank you for taking some time to hear about what I consider my favorite topic, which is sickle cell disease. Today we'll be talking about what I like to call the Sickle Caste, and sort of the story of how we've gone from a single mutation to victimization and how we're going to work our way backwards. Before I do that, I want to share some disclosures with you. The most important one is that I am currently serving as the medical director of clinical development in the sickle cell program at Agios Pharmaceuticals. The opinions and positions that are expressed in this presentation are mine and don't necessarily reflect those of the company. I also have other disclosures that are listed here below. But perhaps the most important disclosure I have to make to you today is that I have an implicit bias. In 2014, I took an implicit association test very arrogantly. As a minority born to a professor of political science who was quite liberal, I grew up in a household where we were having conversations about other religions, other races. My father worked for the Anti-Racism Secretariat in the government of Canada. When I took this test, I took it sort of presupposing that I had no implicit bias, that I was, of course, a physician who practiced medicine without race ever interfering in my decision-making. So you can imagine my shock when the test comes back and says, you treat white patients better than Black patients. Now, of course, I went through the whole spectrum of emotions you could imagine. I went through disbelief, the test is wrong, right? This can't be true. I went through anger, but a few weeks later, I came back and took that test again, and it showed me the same result. And as a physician who took care of 800 plus sickle cell patients in inner city Detroit, it became clear to me that even if this test was wrong, if there's some chance that this test is right, which it absolutely is, I have to make sure that I'm doing everything I can to ensure that the bias that I have is not playing into how I'm treating my patients. And that was the best thing that could have happened. That test telling me that I had an implicit bias changed the way I practiced medicine. It changed the way I thought about medicine. It changed the way I interacted with patients. So I'm not here to speak to you all today. I'm here to speak to myself. See, because these talks are a reminder to me to humble myself, to recognize that I am not perfect. I do not have a completely objective point of view all the time. No human can. Well, what I'm here to do is implore myself and hopefully the rest of you to be able to say, yeah, I have biases, and that's okay. That's the human condition. What we need to be able to do is talk about this without making it personal, without making each other feel threatened, and acknowledging that biases exist. I'd like to start first with a poem of Walter Clement Noel. And let me just move this here. One sec. This screen is in my way. All right. My father in high school gave me a book by the poet Langston Hughes. He was a poet himself, and he told me that this book would make me a better human, and I believe he was right. And I'm going to share a poem that reminds me of the sickle cell patient. I too sing America. I am the darker brother. They send me to eat in the kitchen when company comes, but I laugh and eat well and grow strong. Tomorrow, I'll be at the table when company comes. Nobody will dare say to me, eat in the kitchen then. Besides, they'll see how beautiful I am and be ashamed. I too am America. The story of sickle cell disease in America is a very long one, but it's uniformly told from the starting point in 1904 with a protagonist called Walter Clement Noel, a Grenadian dental student who comes to the United States with dreams of furthering his dental profession. And as he arrives by boat to New York State and then on his way to Illinois, something that he had experienced many times in his life happens once more. He's struck with pain, fever, and difficulty breathing. So he goes to an emergency room in 1904 as a Black male, and something amazing happens. He's treated respectfully. He runs into a guy named Ernest Irons, the intern assigned to this case. As he's being worked up, Ernest Irons does something that's very atypical for sickle cell patients. Ernest Irons orders every appropriate test and even extra ones. Of course, the extra test he orders is the one that eventually unlocks the crucial finding in sickle cell disease. He orders a blood smear. And when he looks at his cells under the microscope, he notices that instead of being disc-shaped, his red blood cells are knife-shaped. They're shaped like a sickle. This story is told with a lot of pride when it's told by sickle cell advocates and physicians. But to me, there's always been something that troubled me about this story, because Walter's experience in the healthcare system is very different in 1904 than it is in 2021. And you'd hope that it'd be different because it's better now. But I can assure you what happened with Walter in 1904 is way better than what happens in 2021. And the truth is, after Walter's case gets disseminated in 1910, it gets published in JAMA by James Herrick. And people around the country start saying, hey, we have patients like this. We have patients that look like Walter. That 1910 JAMA publication is then paraded around as the first publication of sickle cell disease in the world. Of course, in the Eastern literature, in the African and Middle Eastern literature, sickle cell had been described for centuries, not in those exact words. But the truth is, even in the Western literature, sickle cell had already been described. It just wasn't called sickle cell disease. See, in 1846, Robert Levy, a pathologist, publishes the case of a runaway slave, in which an irritable man is described as someone who runs away, escapes the plantation, is found, caught, convicted, and then executed. His body is turned over to the pathologist that paid the most for it, for an autopsy. And the report of the autopsy in 1846 by Robert Levy says, the poor unfortunate man had leg ulcers and an absent spleen. You see, this is probably the first description of sickle cell disease in the United States. In 1846, a runaway slave convicted and executed without cause. The reason I tell this story is because this is the truth of sickle cell disease. There's no glory for patients with sickle cell disease. So as we talk about this, the first thing we need to do is acknowledge that we cannot talk about sickle cell disease, a disease that exists in this country as a direct result of the transatlantic slave trade, without talking first about racism. And we cannot talk about sickle cell disease without first acknowledging that the American healthcare system is built on discriminatory and racist structures that affect all of us, of every color, because we are prisoners in the same system. And today we'll talk a little bit about that system. When we talk about racial healthcare disparities, we obviously know that non-minority populations receive higher quality healthcare. That's not up for debate. The reason that this difference stems is beyond clinical appropriateness and patient preferences. What we're talking about is the operation of healthcare systems and legal and regulatory climates. We're talking about discrimination and biases and stereotyping that cause differential treatment of minority patients. That's what drives disparity. And this, of course, plays out in every realm of healthcare. We're not just talking about sickle cell disease here. Let's talk about cardiovascular disease, where if you're Black, you're 3 times more likely to develop it and 2 times more likely to die from it. You're less likely to receive the treatment of choice. You're less likely to get the preventative measures you need. You're more likely to be kicked out of the hospital sooner. When we talk about kidney disease, Black patients are more likely to get dialysis and less likely to get life-saving organ transplant. When we talk about cancer, as an oncologist, the National Cancer Institute tells me if Black patients get the same care as white patients, their survival rates are equal. Well, we know that that's not true. Black patients get later diagnosis, they get later treatment, they get less intervention. And even beyond that, we talk about more obesity, more diabetes. We talk about, more rates of breast cancer, higher rates of colorectal cancer. We talk about asthma, low birth weight, preterm mortality, mental health. In fact, the disparities are so many that it's easier to talk about the only 2 reverse disparities that exist. That is, 2 things that are more likely to happen if you're Black as opposed to white when you walk into a hospital. And those 2 things are being prescribed antipsychotic medication and limb amputations. I'll give you a minute to process that. It certainly hits me every time I say it. In 1999, Shulman and colleagues at a cardiology conference do something interesting. They take 8 actors who describe symptoms and sort of present in a way that really should drive a physician towards life-saving diagnostic cardiac catheterization. And in this conference, as these actors play out these stories, the cases are told. When it comes down to it, as Shulman and colleagues are going through the data, they find that the people most likely to get cardiac catheterization based on the results of these 700 plus cardiologists at this meeting show that the white male was most likely, the Black female least likely. And he tells us that race and sex both play into how these physicians are making their decision. When we look at Hoffman and colleagues and what they tell us, Well, let me back up just a little bit because we can't talk about current literature without setting some precedent. Let's go back all the way to 1851. In 1851, Samuel Cartwright, a slave physician, coins a term called dysesthesia aethiopica. Dysesthesia aethiopica is a condition that affects slaves. They have thicker skin, he tells us, which requires regular stimulation in the form of beating and whipping and things of that sort. He basically gives a green light to horrible people to do horrible things. This is 1851. And you'd say, Dr. Z, that's 1851. We're in 2021. Tell us about today. Well, you'd hope that things were gone. But you have to remember, medicine builds sort of vertically. It stacks on itself. And as it stacks, it's really hard to shed remnants of the foundation that you're built upon. So Hoffman gives an online quiz to a general population. And in this general population, she finds that 20% of the people think Black nerve endings are less sensitive than white nerve endings. Then she gives the same quiz to first-year medical students, second-year medical students, third-year medical students, and medical residents. And you can see numbers are low, but they're still too high. Then she asks the question, is Black skin thicker, or she frames a true or false? Black skin is thicker than white skin. Almost 60% of the general population believes that, and look at this. 40% of first-year medical students, 42% of second-year medical students, 22% of third-year medical students, and a quarter of medical residents presently believe that Black skin is thicker than white skin. But this isn't a surprise to any of us, right? We just saw this happen with COVID. We just saw how race and racial health disparities play out through disease in this medical system. If you're Black or Hispanic, Indigenous, your chances of dying and death multiply. They increase. This healthcare system is not built to appropriately care for people of color. This, unfortunately, though, is not the only reminder we have about how far apart we are on race in this country. We unfortunately get this reminder regularly. When I first was building this slide, I was looking to see how many Black people died from police brutality since the year 2000. I found the list, I copied and pasted it into the slide, and PowerPoint crashed. Okay, it couldn't process the amount of names that were there. And of course, this list is already outdated. In May of 2020, George Floyd, while being strangled basically with a knee on his neck, is saying, "I can't breathe." He says it 20 times before he's finally killed. The country erupts with chants of Black Lives Matter, fighting for racial equity, appropriate treatment. This isn't the first time that this has happened, but it was polarizing. And all I could think about in that moment, despite knowing how big that struggle is, all I could think about was my sickle cell patients. Because since the time of Walter Clement Knoll onwards, sickle cell patients have been fighting the same battle, not in the street with police, but in hospital beds with physicians and nurses. They've been fighting disbelief, and they've been fighting people rejecting their DNA. And when you take a minute to think about it, see, sickle cell disease is a disease in which life-giving, disc-shaped red blood cells that are built to deliver oxygen to various tissues in the body become sickle-shaped, knife-shaped. They become daggers that get pumped through the body. They rip through the organs. They get stuck in blood vessels. They prevent the onward flow of oxygenated blood, taking oxygen away from tissues, causing pain. So when you take a minute to put that together, sickle cell disease is the physiologic manifestation of I can't breathe. These stories tie together in more ways than one. In 1941, Linus Pauling, Nobel laureate Linus Pauling, mind you, comes out with this newspaper interview. Now remember, Linus Pauling, of course, unlocks the molecular defect that happens in sickle cell patients and is given all of the praise and Everyone falls in love with that mutation, a single nucleotide change causing a disease, a single protein change. They fall in love with the physiology of the disease, but they don't fall in love with the patients that carry that mutation. This is a direct quote from Linus Pauling, Nobel laureate Linus Pauling. I agree we should keep these carriers from marrying one another. I've advised, not entirely joking, that individuals should have tattooed on their foreheads symbols for the defective genes they carry. Or maybe it'd be better to tattoo the symbols in Braille on their abdomen. That's difficult for me to even say out loud. This is 1951 from the man who pioneered how we think about sickle cell disease. And I can tell you that this is the thought process that we've been fighting for 70 years. This is how the medical system still thinks of sickle cell patients. And it plays out everywhere. Let's look at the literature. Shapiro and colleagues tell us 53% of ED physicians and a quarter of hematologists think that probably 20% of sickle cell patients are addicts. When we look at Carlton Haywood and what Carlton Haywood, one of the premier sickle cell physicians in the world at Emory, tells us about how long sickle cell patients wait in the emergency room, he tells us that on average, nationally, sickle cell patients wait 25% longer in emergency rooms. Paula Tanabe in North Carolina tells us that despite there being national guidelines that tell us within 1 hour of a sickle cell patient hitting an emergency room in pain, they should be given pain medication, patients are waiting 2, 3, 5, 9, 11 hours before they get their first pain medicine, as their body's being deprived of life-giving oxygen, as their cells are becoming knives, literally, that are being pumped through their body. Jeff Liebensberger and colleagues do an interesting study. They say, you know, we wonder how much stigma, self-perceived stigma, patients who say, I'm being stigmatized against in my healthcare center. How does that look? You know, how does that look with quality of life? So he categorizes people into 3 sort of buckets. Those who don't believe they have stigma, those who are neutral to it, and those who believe they are stigmatized or are victims of racial bias in the healthcare center they're treated at. And those groups are shown in this graph as green, yellow, and red. And you see the green group, the one that says, there's no bias against me, there's no stigma here. Their quality of life as they get older stays high. The neutral group kind of stays neutral, and that group that says, I'm being victimized here, there's bias, there's a real stigma against sickle cell disease, well, guess what? Their quality of life deteriorates. There's something there. Curious minds wonder. Let's keep talking about quality of life for a minute. Shown in green here, the pediatric population, shown in yellow, the adult population. You can see that when we look at children with illness, sickle cell disease, and literally having cancer and receiving chemotherapy, essentially line up when we talk about how quality of life looks. They line up. That's not how we treat these children, though. We don't treat sickle cell children as though they have the same quality of life as children with cancer who receive chemotherapy. Absolutely not. For adults, in fact, it's even worse. It's even worse. The quality of life of adults who are actively on treatment, receiving chemotherapy, having literally poison pumped into their veins, have a better quality of life than adults with sickle cell disease. It's amazing. It's overwhelming even. Robert Scott in 1971 says, I'm gonna do a landscape analysis of how funding looks. Maybe change in funding will help us. He wasn't off. In 1967, the data he's reporting from, there were 1,155 new cases of sickle cell anemia, 1,200 of cystic fibrosis, 800 of muscular dystrophy, and 300 of phenylketonuria. Volunteer organizations, though, raised 1.9 million for cystic fibrosis, 7.9 million for muscular dystrophy, but less than 100,000 for sickle cell anemia. The first grant, in fact, given for research in sickle cell disease comes from the Black Panthers before they're labeled a terrorist organization. You might say, Dr. Z, things are different. Again, this is 50 years later. Tell us how things have changed. I wish I could tell you how things have changed. Unfortunately, I cannot. See, there's a child born with sickle cell disease every 2 minutes. And in this country, we have 100,000 individuals with sickle cell disease compared to 30,000 with cystic fibrosis. But when we look at funding, the total funding per affected person with cystic fibrosis is about $11,000. And for those with sickle cell disease, it's $943. How do you make progress then? How do you make progress when the funding disparity is this large? And the funding disparity exists purely because of the color of the skin of the people it affects. Well, look, it plays out then, right? This is going to play out exactly. This is a story you know how the story's going to end. The story's going to end with more FDA-approved therapies for the disease that is better funded, more publications for the disease that's better funded, shown in green right here, and less publications, less FDA-approved therapies for the disease that's less funded, right? This is a story with a predictable plot that's just reminding us of the heartlessness of this medical system. And of course, that type of progress, lack of publications, lack of FDA-approved therapies, will play out then in how long people live. You can see in 1979, the pediatric population had this huge, sort of this bimodal peak of death. And interventions like introduction of penicillin prophylaxis, newborn screening, advanced vaccinations, they dropped that first peak, thankfully, of mortality in pediatrics. But adults with sickle cell disease, man, are still dying. They're still dying. The mean age of death in 2006 was 39 years old. That's 30 or 40 years less than their peers without sickle cell disease. We have a lot of work to do in sickle cell disease. And for a disease that's classified as rare, but is actually pretty common out of the rare diseases, it's really sad that we're still this far behind. So you must be thinking, well, that's all great, Dr. Z, but why are you telling me about this? What can I do about this? I don't understand how this plays into bias. And where does implicit bias come in here? How am I going to make a change, right? Well, it's important to hold on to hope. A sickle cell warrior named Hertz Nazaire once told me. It's important to hold on to hope. And in 2007, Alexander Green and colleagues go back to cardiology and they say, we're going to do a study. We're going to look to see if the use of thrombolysis or clot busters changes based on the patient's race. So they do a couple things. They first say, let's ask these guys. Let's ask them if they treat Black and white patients differently. And of course, physicians, the almighty physicians, say, absolutely not. We don't have an explicit bias. We treat everybody the same. We don't see color. It's that narrative, right? So then they give them an implicit bias test. And then the implicit bias test, of course, it shows that there are clearly there's a clear group that has an anti-Black bias and a group that doesn't. And then he checks to see if you have a low anti-Black bias, do you treat Black patients with thrombolysis? The answer is yes. And if you have a high anti-Black bias, do you treat Black patients with thrombolysis? And the answer is you're less likely to do that. But then they do something magical. They take a small portion of that study group and tell them what the study is actually checking for. They say, hey, you know what? We actually checked your implicit biases. And now we're going to see how your implicit bias actually plays into your decision-making. And it seems like you might have an anti-Black bias. Nobody wants to hear that, right? But look what it does. The group that knows that their implicit bias is known, suddenly, despite having high anti-Black bias, are prescribing thrombolysis a heck of a lot more. Isn't that interesting? Because what that tells you is that as individuals, we can recognize, modulate, and counteract implicit bias, but there's one key. The key is you have to know it. You have to know it exists. Because once you know it exists, you can actually think about it. You can address it. And I'm here today to tell you, if you remember nothing else from this, I'm here to tell you, it's okay to have biases. It's completely normal to have biases. It's a condition of human development. You have biases. They may be gender, they may be ableism, they may be race, they may be religion. They exist. We all have them. Recognize them and ensure that they're not playing into your decision-making about how you're treating people, especially if you're in a position where you can influence or exert power on them. So racial health disparity can be driven in a lot of ways. Of course, persistent discrimination in sickle cell disease drives physiologic and psychologic stress. It's well known that stress in sickle cell disease has physiologic consequences. And this can drive health disparities. Absolutely, you can intervene there. Physician implicit bias, for me, shows up as disparities in my ability to make decisions. It shows up in my ability to seek consultation, send a patient for an extra test. That causes racial health disparities. But the one that I've chosen to focus on myself is the last one here. Physician implicit bias playing out in the way clinical communication happens. How are we talking to patients? Are we talking to patients in a way that cause negative patient reactions? Because those negative patient reactions then cause patients to withdraw from the healthcare system. And that drives racial health disparities even more, right? So this is where I have been focusing my efforts. I'm going to give you a little mnemonic here. Implicit, introspection, mindfulness, perspective taking, learning to slow down, individuation, checking your messaging, institutionalizing fairness, and taking two. These are a lot of good ways to help counteract reflexive implicit bias playing into your decision making. The first one I've already implored that you take a minute, go to implicit.harvard.edu, find your implicit biases, understand them, accept them, humble yourself. None of us are perfect. Mindfulness and taking two kind of go together. Mindfulness and learning to slow down, I should say, go together. Not being reflexive in the way you speak and the way you talk, particularly to stereotyped patients, comes from taking a minute to just slow down, reducing your stress level, just bringing everything down a little bit. Really helps in your approach when you're dealing with a patient that may be feeling stigmatized. Perspective taking, understanding the point of view of the stereotyped population. This can happen by interacting with them. This can happen by reading about them. This can happen by watching documentaries and videos about that group you're interacting with, despite no matter what your bias is. And for me, the one that has made the most difference is individuation. See, when you sit down with somebody and they become more than the patient, the student, they become Hertz or Blaze or Andre or Phil, you realize that you have more in common than not. You have more in common as human beings. Sickle cell patients don't deserve to be clumped together in a bucket because they have one nucleotide different from you in their beta globin gene. Their mothers and fathers, they have the same issues that you're dealing with. They're worried about who's going to pick their kid up from school. How am I going to get to soccer practice? Am I going to be able to pay my bills? It's the same human struggle. Individuating those people makes all the difference in the world. Of course, checking your messaging, institutionalizing fairness. These are two things that clearly are happening at UMN based on what I'm seeing with this DEI group here. And the last one is to take two. Take two. This is not something you fix overnight. We make ourselves better slowly, over time, lifelong. This is going to be a lifelong journey of ensuring that you're combating these implicit biases. Pat McGann and Alexandra Power-Hayes, I know we're getting close on time here, but Alexandra Power-Hayes and Pat McGann give us a framework in their NEJM editorial on how we can reduce the impact of racism on patients with sickle cell disease. Well, it comes in three ways. So reducing the impact of structural racism, right? So structural, I would even call it structural violence maybe. Implementing sort of universal screening for social determinants of health, reintroducing federal funding for sickle cell disease centers, understanding why federal research disparities exist, and providing psychosocial support for sickle cell disease. Dismantling institutional racism, allowing instances of sort of racism to be reportable, hospital-based. The way we report blood culture positivity or skin ulcers, we should be able to report these types of events in a safe way, both patients and staff. Having anti-racism and DEI task forces, patient management protocols that are either personal or at least stand up against national guidelines. And then, of course, addressing interpersonal racism, speaking explicitly about race with the medical teams, with the teams you interact with, developing partnerships with patients and using them to leverage their personal experience in helping people individuate sickle cell patients. Practicing mindfulness and self-reflection when caring for sickle cell disease patients. Never using the word sickler when we're talking about a sickle cell patient, and educating the colleagues who do that. The National Academy of Sciences lays out a strategic blueprint last year that pulls in the opinions of sickle cell key opinion leaders, sickle cell patients, advocates, really a cross-functional team with this vision of long, healthy, productive lives for those living with sickle cell disease and sickle cell trait, based on these foundational principles to guide us over the next decade as we try to improve things. And really what they come up with is these overarching issues and what the drivers of change will be, which are research gaps, funding limitations, workforce needs, and advocacy. The goal here, of course, is to get to healthy, productive lives for individuals with sickle cell disease. And this is a lifelong journey for those patients as well. What I want to do, though, is not end with words from me. I think it's appropriate that we end with words from a sickle cell patient. This sickle cell patient is named Blaze, and I want to share a poem that Blaze wrote as we wrap this talk up.
Hello, my name is Blaze Eppinger, and now I'll recite for you a poem that I wrote about sickle cell and my life battling it, as I have sickle cell disease, hemoglobin SS. I live with the pain that doctors will never see. To live, I need blood from strangers I'll never meet. Not saved by Superman or a thunderous God, but by someone that has a family and a regular job. I'm in ICU with the tube for breathing and one for food. Can't get excited or too down, I'm keeping an even mood. Cause I live my life free, but still inside of a cell. Hoping for an appeal, hoping that I excel. My cell's breaking down, but seriously I could tell. I was built for the rain, catch it all like a well. And I done made it thus far, through the worst pain, even through the rough parts. Doctors used to say 30 years would never come. But every year on my birthday, I celebrate another one. Thank you.
And with that, I'll open it up to questions.
Thank you, Dr. Zaidi, for the very interesting discussion or lecture. And you can either type in your questions on the chat box, or I'll try to monitor if you are raising hands. There's a comment from Joanne Beckman. She says that when I heard about Mr. Floyd, I checked our sickle cell patient list to make sure he was not one of ours. It should be noted that Mr. Floyd had sickle trait. One of our fellows, Dr. Ivy, has a very powerful talk regarding Mr. Floyd and how sickle cell trait has been used as an excuse to justify law enforcement, mediated homicide of Black men and women.
Yeah, this has been a key topic amongst the anti-racism task force at ASH. We've been working quite hard to sort of figure out how to address this.
So there's a question from Dr. Cloyd. Is there evidence that racially based disparities in health are improving? And if it is, what is the cost for this improvement?
So before I answer that, I'm going to go close the window because the dog outside barking is driving me insane. Give me 2 seconds.
Sure. So in the meantime, you can put in questions here in the chat box or raise hands.
All right, sorry about that. So I've got to say, I don't think that we are at a point where we can say there's any data that's showing that this is getting better. I think right now, all we can say definitively is that it's going to take a lot of work to undo everything that this has been built on. It's going to take us many years to address not only the challenges that we need to address within healthcare, but what has been the biologic epigenetic toll on Black patients that are going through these stresses that this cage of structural violence has placed on them. How is that going to play out in future generations? I think that's all unclear in the moment, but very, very real.
Ray, did you have a question?
Hi, Ray.
Hello, Dr. Z, and thank you for speaking. It is such an honor to always be able to hear you speak. So just in full disclosure, I run the Sickle Cell Foundation of Minnesota, and yes, Dr. Z and I do know one another. But what I'm wondering is, after having spent several years in the pediatric sickle cell clinic, one of the things that I saw the work that was being done around DEI was, to your point, beginning to document what we called respect and dignity, right? And though it may not have been an obvious medical infraction or something that needed to be measured there, what we were measuring was the ability of people to see something, say something. And then what would we do with that information? Because one of the things that I get concerned about is that we those of us who are in DEI spaces, we have these talks and we talk a lot to one another about these issues, and we begin this process of just preaching to the choir. But the individuals who may need some reflection points in ways that they can restructure how they present care are not always in the environments that can benefit to that thought process. So what are we doing to get upstream of that, right? Being in medical schools, changing some of the curriculum, Dr. Cartha offering courses that dig a little bit deeper into some of the challenges that are being faced by many in rare disease communities where they're not getting the attention or the dollars that they deserve. Can you tell me how your work and others who are in spaces like yours are able to impact the upstream challenges?
Thanks, Ray, for that as always, thoughtful question. You're right. There is this sort of circular wheel that we get stuck in, where we're talking to people who are like-minded always. We're talking to people who already want to hear this. Talking to the people who don't want to hear this, for me, has generally happened in the healthcare setting, right? It's happened with colleagues who have very clearly let their bias peek its head into how they're treating patients. Those interactions, for me, have been probably the most robust in their ability to change actively what's happening to sickle cell patients in that moment, right? But that's not enough, because that has to be happening at every hospital, everywhere, all over the country. And there's not advocates in all of those spaces. I think what you're going to start seeing, though, is, first of all, I've got to say the American Society of Hematology has fully embraced sickle cell disease as its flagship project to push forward against bias and sort of systemic racism that plagues this disease space. What you'll see is, for example, this year at ASH, we're going to have health equity rounds that are being given by Dr. Drew Campbell and Maureen Achebe on sickle cell disease for the general ASH membership, right? Whether you're a sickle cell doctor or not, right? There's curriculums being put out by ASH. I think you're exactly right in that for some of the older generation, it might be too late, right? And we've got to start much earlier. We've got to start with I like to call them reticulocyte stage trainees, right? The reticulocytes, we've got to start with them. So the med students, the residents, the fellows, right? So when I make rounds, yeah, if you have an acute chest syndrome patient, you take care of the acute chest syndrome. We'll talk about it for 10 minutes, but we're going to talk about anti-racism and implicit bias for 10 minutes as well, right? Because that's part of the curriculum. That's part of their education. So it's going to take those types of grassroots efforts to push this forward. I think right now, see, the other thing that I want to say, Ray, is that sometimes we worry about like painting the room while the house is falling down. And that's kind of what's happening with doctors for sickle cell disease. We just don't have enough of them, right? They're not out there. Patients are missing basic medical care. And I think that the first thing that we need to address at a national level is that discrepancy. How do we pull more doctors into the sickle cell space? What is the federal government going to do to help us with that? And as we get that sort of sorted out, let's then figure out how to institute systems like you're talking about, right? That make transparency the norm amongst reporting these types of events. Anyways, that's a non-answer to your very eloquent question, but that's the best I have for you right now.
Yeah, and there's a related question in the chat box is about how do we as an institution continuously assess our curriculum to further identify implicit bias in healthcare and minimize institutional bias? And are there assessment tools that could be used for our current curriculum?
So that's a good question. There are a lot of, I honestly don't think that any of them are great, if I'm being honest with you. So as chair of the Anti-Racism Task Force for Hematology, one of the things that we were designated, one of the tasks was exactly this, is create a curriculum and then figure out how to measure how that curriculum's working. Well, I mean, it's really hard to do that. You can have implicit bias assessments on some routine basis, but even those tests they're not perfect. They're not great. They're good. They're okay. They're the best we have, but it's hard to sort of track that longitudinally. I think what you want to work on is measurable patient outcomes. How well supported are your sickle cell patients? How long does it take for them to get medication when they need it? What's the ratio of physicians that are caring for your sickle cell patients, right? How many nurses do they get? I think those types of things, those institutional things are a little bit more measurable. That institutional racism is something that can be tracked. Interpersonal racism is a little difficult to track.
Okay. And because we are from the pharmacy school, do you have any advice for our curriculum developers?
I think that understanding, I think one thing that I run into, the way I interact with pharmacists most is obviously in prescription of medicines, but also most often when I'm doing peer reviews, I feel like the person on the other end of that peer review call is 90% of the time a pharmacist, to be honest. And I think what I've noticed is that we don't spend enough time teaching people about sickle cell disease. If you think about any other disease in which there are 100,000 patients and 1 in 12 people who are Black carry the mutation, you would expect that this disease would be talked about a ton more. In medical school, I can tell you it was a paragraph, a couple paragraphs, right? Everything I've learned about sickle cell disease has come from people like Ray. It's come from, advocates and patients. It's come from being in the room with patients, and that's where you learn. I think if you can figure out a way to spend a little bit more time educating individuals on this disease within your pharmacy school, you do well for the whole community.
Sure, I mean, and there is a question about funding, like what is the current stage? And I think Joanne has answered that, especially with gene therapy, gene editing technologies like CRISPR coming into the picture. Do you think that funding for sickle cell disease would increase? or has it increased?
Yeah, so it's not nearly where it needs to be, right? It's maybe going up a little bit, but not in the way it should, not in the way it should based on how many people it affects. You know, gene therapy is a double-edged sword. I'm excited about it. I'm happy about it. The science is cool. It's not a right now answer for the vast majority of sickle cell patients, right? And it's not going to be for a very long time. I think that we have a long way to go. Let me not be so dreadful though. Look, there are currently 4 FDA approved therapies for sickle cell disease. There are maybe 20 more in the pipeline. We are at a point, I would say, a nexus point. We're at a point where what happened to leukemia in the 1970s and 1980s is kind of where we're heading with sickle cell disease, where people started realizing, hey, maybe if we combine methotrexate and steroids and 6-MP and all of these other things, we'll get better outcomes. Childhood leukemia, that's what happened. And childhood leukemia, ALL, is basically cured at this point. I think we're getting to a point now where we're understanding the tools in our toolbox. Up to this point, all we've had is a hammer, so every problem has to look like a nail, right? But as we're starting to understand the sophistication of the tools in our toolbox and we're learning how to use them well, it's going to get easier. I urge you guys, though, as you know, as people in the pharmacy school, try to reduce any roadblocks that you may be responsible for in patients being able to see these new medicines, whether it's in any form, because you guys touch the system in so many different ways. However you can do it, try to reduce those roadblocks as much as possible.
Yep, thank you. And there's another question about, are you aware of any health systems that have included racism or implicit bias in their event or error reporting processes? Any thoughts on doing so?
So that is 100% what needs to happen. It needs to be available for not only staff, but also patients. And I can tell you that I've heard a lot of talk about it from a lot of different healthcare systems, but I have not seen it implemented yet.
Okay. And Ray had one more question. Any thoughts on how healthcare system can protect providers and other healthcare professionals who speak up about institutional bias? How do you protect these champions from potential retaliation that is ever present?
Yeah, so that is a very real problem. This is what the great John Lewis called good trouble. There's a lot of good trouble when you stand up for sickle cell disease. And it happens a lot. I am very well known to be in the principal's office quite frequently for the good trouble that I cause along the way. Look, if you're not getting in trouble for what you're saying, you're probably not saying the right things, as far as I'm concerned, when it comes to sickle cell disease.
That is really true.
It becomes really hard, though, when you're a caregiver, when you're a parent, seeing your child being treated poorly. It becomes really, really difficult to walk the line of advocating and making sure your child gets the care they deserve to have, because the almighty physician is very sensitive and very, our feelings get hurt fast. So if we get challenged, sometimes we start providing subpar care. Those are facts. I think, Ray, there's no easy answer there. I think you've got to advocate. You just got to figure out the most effective way. And I think of the advocates that exist in this country, you've probably done it best.
Thank you, Dr. Zaidi. Any other questions for Dr. Zaidi? Anyone can unmute yourself and ask too, if you don't have to type it in.
Everybody's post-ictal after their lunch. That's what's happened.
No, I just want to say I appreciate that. And to your point, good trouble, we have to become comfortable with good trouble. And we have to be willing, to stir the pot and create some waves, not in an effort to, point the finger at individuals per se, but at a broader system that we have to begin to dismantle, and being able to maintain that level head while you're advocating, but you are also conversing with another human being who is susceptible to the very same feelings, defensiveness, and things that we, or the person on the other side is also susceptible to. And so it is a very thin line, and it is a lot of time in the principal's office, but it's also a lot of time of reflection of ensuring that the message that you're bringing is a very difficult message. In the state of Minnesota, we all know that you are there's sometimes a challenge with having difficult conversations and being received. However, how we do that in the most effective way to get the message across, some of that is a bit of code switching, I have to say, and how we learn to speak that truth to power in a palpable way without losing the impact and the importance of exactly what we are trying to say. And that's an art, and that happens over time. And the more that you put yourself in those situations and environments, the more that you develop that skill. It's a muscle. And so you are one person that does that incredibly well. And I believe that it has projected you into environments in which you can speak truth to power and it be received. So thank you for all that you do in the community.
Thanks, Ray.
Thanks, Ray. Bob, did you have a question, Bob? I see you have unmuted yourself.
I guess I am unmuted. Well, I'm an older white clinician, and I'm aware that I have biases, but I think a huge problem is that of communication, and it's we have one language, our patients have another, and we really need practice in how we're affecting each other. I think one way to do that would be actually to have practice sessions, maybe with actors or with patients, but recording and then look at yourself and see, boy, I really screwed up there. There's a real skill, and you're much better at it sometimes than others, but it's a humbling experience.
So first of all, Bob, I appreciate that comment tremendously. I think you're exactly right. I mean, clinical communication is, like I said, I mean, that's an area where I felt I was also deficient. And for me, my personal project became a podcast, which allowed me to communicate with my patients a little bit more clearly. I want to address your first comment, though. You said you're an older white clinician. Here's what I want to say to that. Being non-white doesn't protect you or save you from having implicit bias or treating other patients or treating patients of color poorly. I think sometimes we forget, people of color, we were raised, Bob, in the same system all together, all of us. So our subconscious has formed very similarly. And I think that it's very real to remember that non-white clinicians can have just as bad implicit bias and racist tendencies, and they exist. And I think sometimes I personally forget that, and I work on that quite a bit myself. So I don't want you to think that, just by virtue of skin color, you are free of any of this burden. It's something that we all are working on.
Thank you. And as we are close to the hour, I just wanted to ask you if you had any one comment for the students who are on the call today, because they're just learning. It may not be a part of their curriculum, but where can they look for these information? What can they do to be better at this?
Well, you guys are really lucky that you have Ray in your community. When you have questions about sickle cell disease, I'd go to her. You know, my one piece of advice though to students is talk to everyone. Talk to everyone. Everyone, wherever you are. Take a moment to talk to, if you get patient interaction, talk to your patients. If you get faculty, go talk to Bob about sickle cell disease and how it looked, you know, over the trajectory of his career. Go talk to Joan and talk about how things have changed. Talk to Ray about the social dynamics. Talk to everyone. You have a wealth of resources around you, and I think that you should utilize them.
That's a very good advice. And before we close, I'm going to have Dr. Johnson close the session, and we do have a small group discussion. So Lauren.
Yes. Well, thank you, Dr. Zaidi, for really being authentic in your message in terms of how sickle cell caste system, just how that affects us today, and that there really hasn't been any change. And we were probably doing better 100 years ago than we are doing now, and that the same problem still persists. Thank you for really bringing about and showing and demonstrating like the inequities that still persist today, and how we potentially can challenge ourselves to do better as staff members, as faculty, as clinicians, as students, and then also as practitioners in the community. And so we would just like to thank you for your honesty, thank you for your presence, and thank you for your knowledge in helping us to move forward.